Welcome to Wellness and Wisdom with me, Dr. Nadu Tuwakli. Here you can expect to hear conversations about everything women over 40 care about. From optimal wellness and peak performance, from intimacy to travel and finances and more. I will be speaking to interesting women and sometimes men to educate and motivate you to live your best life. If you want to find out more, please head over to my website, drtwakli.com, or subscribe to my blog. You can also read my book, Sex, Sanity, and Sleep. We are in this together. Hello again. Welcome to this edition of Wellness and Wisdom with Dr. Nadu Tuwakli. As you know, the aim of my podcast is always to enable women to reach their full potential. I want you to listen to my podcast and leave with a head full of ideas. And it's not just for women. Men need to be our allies and try to understand what makes us tick. So steer them this way as well. So I started this podcast to delve into women's empowerment and what it really means. Because women need to learn to trust themselves and the decisions that they make. So my goal is to provide accurate, transparent information that will help you make those decisions. The goal is to live life well and be optimistic and realistic about the future. I hope it'll be more of a dialogue than a one-way narrative. Today, we're going to talk about a very important topic of hormone replacement in women. If you want to go further in depth in the subject, you can pick up a copy of my book, Sex, Sanity, and Sleep, but not just book stuff. My guest and I will get deep into real questions that plague real women. How to improve a woman's sex life and what she can supplement to remain orgasmic. What are the best supplements to help sleep, especially if you don't take progesterone? How does estrogen deficiency promote dementia? Can you take hormones if you have had breast cancer? If so, which ones? And how can you best protect your bones as you get older? All kinds of stuff. So before I introduce today's guest, let's just cover a few basic physiologic facts as a foundation for our discussion. There are two kinds of hormones, steroidal and non-steroidal. You're probably very familiar with the non-steroidal, such as insulin and thyroid hormone. The steroid ones are made from cholesterol. Yes, our good friend cholesterol that your cardiologist tries to beat into the ground, but it is there for a purpose. So the first step from cholesterol is pregnenolone. So that's the granddaddy of all hormones downstream, and this includes your stress hormone, cortisol, from progesterone, and the sex hormones, estrogen and testosterone, from DHEA. Estrogen and progesterone are like the yin and the yang. They balance each other. And there's a receptor for estrogen and progesterone in every cell of your body, including your tongue and your eyeball. It's important to give the body adequate building blocks so that in its wisdom, it can make what it needs. You don't always have to provide the end products all the time. So just a couple of definitions before we get into this. Menopause is when your ovaries stop making hormones, and it's official once you haven't had a period for a year. The perimenopausal phase is the transition phase leading up to menopause. And believe it or not, it can last up to 10 years. All your hormones begin to decrease after 35, except when you're pregnant. And then there's one last definition, post-menopause. And this is when you haven't had a period for a year after you became menopausal. Today, I'm talking with a compounding pharmacist who specializes in GYN concerns, including PCOS, which is polycystic ovary syndrome, PMS, which is premenstrual syndrome, and menopause. Today, we're going to talk about all this stuff and female sexual dysfunction, and then hopefully in a future episode, we'll get a chance to discuss the PCOS and the menstrual issues. So my guest today is Dr. Sharzad Green, a pharmacist who specializes in natural hormone replacement, adrenal dysfunction, nutritional supplementation, and Dr. Green specializes in many other things. She's well known for her innovative pharmacy practice. She enjoys interacting with both male and female patients and provides direct patient care. Dr. Green has helped over 20,000 patients, guiding them through hormonal challenges, adrenal and sexual dysfunction, and recommending supplements. She, like me, is passionate about educating women and showing them how to optimize the way they feel. She'll give us some examples of her coaching and how this has helped women through hormone imbalance. Dr. Green got her doctorate at the University of Arizona. Welcome to Wellness and Wisdom.
Well, thank you. It's great to be here. Thanks for having me.
So we're happy to see you because people always have questions for the pharmacist, and I'm hoping we can pretty much cover not all of them because that would take 4 episodes, but the main ones at least. And so people have a comfort level with the whole idea of compounding. First off, can you explain to our listeners what is the difference between a compounding pharmacist and the one you see at the supermarket or the drugstore chain?
Essentially, we all go to pharmacy school, and as of 1990, the pharmacists who graduate in the US have a doctorate degree. Whether they choose to work in retail setting or hospital setting, clinical, or a compounding setting. A compounding pharmacist basically has the option of obtaining raw ingredients and making those ingredients into a formula that would be appropriate for a patient. So a simple formula for compounding, for example, is if you are working in a retail setting and a patient brings you a prescription for their child for a cough syrup, but the child does not like the flavor. But the mom says, but my baby really likes, I don't know, the taste of strawberries or whatever. So then you can flavor that syrup for them. That is just the simplest form of compounding. But then in the bigger scale, what we do is, in addition to all of that, we actually specialize in making things from scratch. Therefore, for example, in case of hormones, we can obtain the raw ingredients, different hormones that are available. They're pure powders, and then mix them in a certain ratio, certain dosage, in a certain base or cream for a patient to apply on their skin. So there's an art to it, there's a science to it, and it takes years and years of practice and training to become well versed in it and actually deliver something that would be of high quality.
Right. So I think in a nutshell, what you're saying is that compounding pharmacists customize the prescription to the particular patient versus the people at the grocery store who just count the red pills and green pills and only one size fits all.
It's basically individualized medicine.
I think the few people that are familiar with compounding pharmacists who don't take hormones are those who have pets, because a lot of people think that a compounding pharmacist is the person that makes the specialized stuff for the pets. We're going to talk about how important hormones are, but I think folks pretty much do know that at this point. Can we talk a little bit about the different methods of administration of hormones since we're talking about compounding? Because a lot of people will say, well, how do I get it? Is it like taking the pill? Folks are just used to taking pills. So can you tell us the methods of administration?
There are some forms that are taken orally, such as capsules, sometimes tablets. Sometimes we make troches or lozenges that dissolve in your tongue or under your tongue, in your cheek. Sometimes it could be drops. So those are the majority of things that we make as far as oral compounds. And a good compounding pharmacist with great knowledge of hormones, they should be able to guide your prescriber, if they're not familiar with it, as to what would be the safest route and the most effective route for a patient. And it all depends on the symptoms and the risk factors. So there's a lot of things that goes into choosing whether you should be on a capsule, troche, sublingual drops versus a topical cream or gel, such as like an estrogen cream that you would put on your wrist. So those are the majority of forms of compounds. Sometimes we do make suppositories that are vaginal for vaginal use. For example, in case of vaginal dryness, that is something that we do. We could either make estriol vaginal cream or make it into a suppository form or even a tablet, a vaginal tablet. And sometimes, for example, if a patient has recurrent UTIs and vaginal infections, sometimes we can add a little bit of probiotic to the formula. So there's a lot of different formulas that we can use.
And can you tell our listeners about pellets, hormone pellets? I know they're pretty popular where you are in Arizona.
They are popular, not with me, but with a lot of other providers. They like to use pellets, and a lot of patients like them too. But the concept is like this. The pellet is, imagine a grain of rice. So they take the hormone estradiol, for example, and they press it to become like a grain of rice. So it's very concentrated. And then they make an incision on the buttocks and insert the pellet inside that incision and then sew it up. Now that pellet is supposed to last the patient probably 3, 4, up to 6 months. Sometimes it lasts longer, sometimes less, depending on your body. But essentially, the body is supposed to absorb that pellet gradually. What I see, the reason I don't like pellets is because oftentimes I see the hormone gets released all of a sudden, so the patient's levels go really high. And once they go up to that level, it's really hard to reverse it. It's just a matter of time, honestly, to try and kind of write it out until it goes down, because you can't really take the pellet out.
Can't take it out.
So
Yeah.
no, that's the reason I don't necessarily like the pellets. I'm aware of the fact that a lot of patients and providers really like them.
So in my experience, number one, I haven't seen a pellet that is as small as a grain of rice, I have to tell you. I don't know if you guys make them smaller over there. They're usually a little bigger than that. And I also find that men like pellets a lot more than women. Men like to get the pellets, I guess, because they feel like, it's going to last them 4 to 6 months and they're always too busy to do anything and they want, stick it in there and done. Women are not as fond of pellets in my experience. And I agree with you that especially if you're starting hormones for the first time, you shouldn't really start as a pellet, because if you find it's the wrong dose, you're kind of stuck with it. It's a thing in your behind until it dissolves 4 months later. So let's talk a little bit about the actual hormones. I always say that progesterone and estrogen are the yin and the yang. And obviously we also add things like testosterone to the compound. The nice thing about the compound is that you can put all 3 hormones into one product. I've seen some people coming from other providers with a bunch of different syringes and tubes and this is that, and I use this on day 14 and I use this on day 15, and extremely complicated. I try to make my protocols as simple as possible. Oftentimes vaginal dryness will improve just with taking a systemic preparation. If the person still has dryness, you're going to have some extra for the vaginal area. Now, one thing that I find is that if you put all the creams in a separate compound, then that costs the patient a lot more. Are you a believer in doing blood tests to monitor the levels?
What I believe in is different than what I end up doing half of the time. I actually prefer either saliva test or blood spot test, where it's kind of like a finger stick. Because when we do regular blood tests, and if the patient is using hormone creams, oftentimes we don't get accurate reading, especially on estrogen and on testosterone. Therefore, it's hard to chase some number that's not accurate. But if you do the saliva testing, it just tells you exactly where the patient is, and therefore you can adjust the dose based on their symptoms and their saliva test results.
Right, and the saliva test also has the advantage of being able to give you the PE ratio, whereas with the blood you can't tell the progesterone estrogen ratio from the blood work, but you can from the saliva test. But before everyone rushes out and gets a saliva test, I'll give you a different perspective. I oftentimes will do saliva tests on people who are perimenopausal, which is the transitional phase, but I don't do it as often in actually postmenopausal women. For one thing, the insurance company doesn't cover the saliva test, and so patients are going to have to pay for that test. And if I use that on a regular basis for monitoring, it gets a little pricey. Whereas if you're perimenopausal, I agree that the blood test really doesn't tell you much, because one day it could be this, one day it could be that. You're in a state of flux and the blood test is just not accurate enough for an assessment. But if you have a postmenopausal woman who's been on hormones for quite a while, I generally will not do a saliva test on them. I'll do the blood test mainly for economics. I agree saliva is the best, is the gold standard. but patients find that the insurance company will pay for the blood test, but they won't pay for the saliva test. But then I don't know about your population. There in Arizona, maybe most people are just self-pay and not even concerned about the insurance. We monitor the symptoms, and if someone is obviously getting better, in general they do, you can pretty much tell when the patient is on a good dose. If you're monitoring with the saliva, how often do you do the saliva test?
It depends on the patient and their symptoms, and
in general,
I would say initially 3 months after we start the hormones, and then again 6 months later, and then after that every 6 months. And it's the same thing for blood tests too for me.
So let's see if we can switch gears here. And we've talked about vaginal dryness, but vaginal dryness is not just an inconvenience in terms of intercourse, right? It also has medical ramifications, such as frequent UTIs, urinary tract infections, discomfort, and atrophic vaginitis. How do you explain that to the layperson?
Well, that's actually one of my biggest pet peeves. So I actually made a product for over-the-counter use for the same reason. Basically, the vaginal tissue has to have estrogen in order for it to be well maintained. Having estrogen means that you're going to have your own lubrication and maintain a healthy vaginal tissue. Now imagine the skin on the back of your hand. If you go out in the cold, dry weather and you don't take good care of it, it's going to get thin and dry and flaky, and eventually it may even crack and bleed. Okay? The same thing happens in the vaginal area. If it's too dry, that tissue can get really thin and dry, and it could crack and bleed. So you could have literally like 1,000 paper cuts. And that's one of the reasons it burns and it hurts. Sometimes, because I deal with sexual dysfunction in women especially, I say it's a part of it is negative association. So if I'm counseling a couple, I say, well, imagine if you and your partner go on a roller coaster ride and you get really sick and you start throwing up. Well, she had a lot of fun, or he had a lot of fun, but then when you land and you leave, you're like, I'm never going to go back there again because it was so horrible. Well, the same thing happens to a woman. So if a woman has this painful experience that's very unpleasant and it's burning not only during but also after, then what makes you think that she's going to want to participate again? Therefore, it's very important to address that issue, even if you don't address the overall hormonal imbalance, because I think intimacy is so important in a relationship, especially. So if you can get that vaginal tissue back to normal, whether by giving estrogen vaginal cream, or there are some other innovative ways and natural ways that you could also try, I always assess my patients and give them some options. I think that makes a huge difference in the quality of their lives. As you said, I'm in total agreement with you. It's not just the intimacy issue, but it's also urinary tract infections, vaginal infections, discomfort, bladder leakage, because when the vaginal tissue is so atrophied, it cannot hold up the bladder as well, so the bladder drops and you may have more incidents or there's leakage.
Now, talking of vaginal dryness and non-prescription products, do you recommend a non-prescription over-the-counter treatment for hot flashes for women who don't want to take hormones?
I have a protocol for hot flashes, whether a patient goes on hormones or not. There are certain things that I always counsel my patients on. I always say find your triggers. The common triggers for hot flashes and night sweats, as most women will know,
Okay.
when it happens.
A good hot cup of coffee.
Coffee, yes. So caffeine, alcohol, smoking, spicy foods, sugars, and stress. So 6 important factors. And you've got to really think twice. And I always say, I don't expect you to give up everything, but remember, it gives you control over some of the hot flashes. At least you don't go crazy like I have no control over these hot flashes. Yes, you do. You can give up certain things. You can do mindful meditation. All of those things do help to some extent. Then there are over-the-counter products. So one of them is fish oil. Believe it or not, a good potent fish oil can actually help with vasomotor symptoms or hot flashes and night sweats. We need at least 600 milligrams of EPA and 400 milligrams of DHA, not DHEA, but DHA, which is in fish oil, per day to help with some of those vasomotor symptoms. So that's another thing. And then, of course, there's a lot of over-the-counter products that include black cohosh, for example. Sometimes they help, sometimes they don't. Some women try evening primrose oil. That one has not been proven to help with hot flashes or night sweats, but it does help with moods. So it's a concoction of different things. And I come from a background where my mom had breast cancer. So for that reason, I've come up with certain things in my toolbox where I can offer patients certain supplements to help them get through this phase of life. At one point, I did formulate an over-the-counter product called FabuVag that was used for vaginal dryness, and it does have the herb fennel. I still have it, but I don't promote it. I don't want this to be a promotional thing. But what I'm saying is there are herbal things that you could also do to help manage some of these symptoms.
To some extent, yes. Because I have not had a lot of luck with herbs over the years, and I've been doing this for 30 years now. So black cohosh, evening primrose. One thing that is overly hyped and has no basis really is soy. They tell you, take a whole ton of soy. Well, how much soy can you take that is actually going to change hot flashes? I see people trying to gulp down all this soy milk and eating tons of tofu. It may work for cultures that eat a lot of tofu, like in the East, Japan. But for the average person, I don't think they can eat enough soy to make a difference to their hot flashes. What about sepia and sabina, the homeopathic remedies? Are you familiar with those?
I don't do homeopathic remedies. I've heard of them, but what is your experience?
If a patient asks for something that's non-hormonal and they've tried all these preparations from the health food store and they want to try something, I'll say, okay, try sepia, SEPIA, or sabina. But as with most things, it'll help some people, it won't help others. I've never found that it particularly takes care of everything. You know what I mean? Nobody takes sepia and then says, I don't have any hot flashes at all, I'm just good to go. No. But along with the other things that you were suggesting, stopping the hot drinks and making some adjustments, it might be, but it's not my go-to be honest with you. We were talking about sexual dysfunction. What do you think about oxytocin?
Well, oxytocin can work for some people, just like everything else. I happen to have a lot of referrals for police officers, and it's very interesting, and firefighters. Those women, police officers, they tend, in my opinion, or in my experience, I should say, they tend to benefit from oxytocin. So oxytocin helps you kind of like relax and let go of that wall that's around you. I always ask my patients before I recommend oxytocin, I say, okay, let me ask you this. Do you enjoy being touched? Are you comfortable cuddling? Are you the type of person who's like, don't get close to me, you like to keep your distance? So depending on their answers, then I can hopefully semi-scientifically decide whether oxytocin would benefit them or not. But it doesn't hurt to try that for a month. I always say, try it for a month. If it doesn't help you, then it's not for you. But for the most part, it does help my tough ladies who have to be protective of their space.
But when you say help, what does it do?
Well, it allows them to let go of that imaginary wall that they've built around them, that nobody is allowed to come close to them. Therefore, they become more inclined to cuddle. They feel more affectionate and they feel more receptive to affection, which would hopefully help in sexual. Because if you don't like anybody touching you, I'm sorry, it's not going to happen. Nobody's going to be able to be intimate with you if you don't allow anyone inside your personal space.
But does oxytocin increase the likelihood of having a climax, an orgasm?
In some patients it does. Based on one study, it actually does, but I'm not convinced that it helps every single time. No, nothing. I have not found one thing that helps every single time.
Nothing works for everyone. I guess we should explain to the listener what oxytocin is, because some of them may not even have heard of it. But that is the hormone that you secrete after you have a baby, and it helps you to contract your uterus, and it makes you all cuddly and touchy-feely towards your baby and that kind of stuff. We've talked about the sexual dysfunction. Do you recommend any other herbal preparations for that actually work?
That's a tough one. That's a real tough one. In my toolbox, when I look at a woman with sexual dysfunction, first we address the vaginal dryness if that's a problem. We check the hormone levels, make sure that they're balanced, of course. There are some prescription things that we make that are not herbal, such as sildenafil cream or Viagra cream, along with maybe arginine or something else that they would put on the external genital area about 15-20 minutes prior to intimacy, because it helps open up the blood vessels and it draws blood to that area. So it makes it more sensitive and responsive. As far as
we call that the scream cream here.
Right. And there are so many different versions of scream cream. You're absolutely right.
Yeah.
Some people call it dream cream also. As far as OTCs, I don't know if it's considered herbal or not, but it's natural. But nitric oxide support formula is the other thing that I recommend.
And it's OTC, which means it's over the counter.
Over the counter, right. Nitric oxide is a natural molecule that your own body produces. And we make a lot of it up until the age of 40. After age of 40, usually our production drops by 50%. So the way we can actually increase our nitric oxide production internally is by eating a lot of red beets and spinach. I'm talking about like pounds and pounds of these things, not just a little bit. But that naturally increases your own body's production of nitric oxide, which this molecule actually is responsible partially for opening the blood vessels and improving blood flow throughout your whole body. We use it for diabetic neuropathy, for example. But in a sense, it may help with sexual function because it improves blood flow to the external and internal genital area. And we use it also in men with erectile dysfunction. Now,
doesn't Viagra work through the nitrous oxide pathway?
Partially it does, but not entirely. It definitely does not improve the nitric oxide, no. But it does help open up the blood vessels the same way. I guess I should explain that vasodilation, or opening up the blood vessels, takes a lot of different mechanisms in the body. It's not just one thing. So all these things do lead to opening of the blood vessels, but different mechanisms.
What is the name of the over-the-counter preparation, if people want to look for that?
Well, there are many different ones over the counter. The one that I like, simply because it's got a test strip and you can actually do a saliva test right there and then. In fact, we offer that at our pharmacy. You come to our pharmacy, it's a free test. You put the test strip on your tongue for 5 seconds, and then we read it and tell you whether you're low in nitric oxide or not. And if you are, then you can purchase what's called nitric oxide support formula. We use Berkeley Life because, again, that's the company that has the saliva testing. And I like the visual when I see the test strip, and I'm like, okay, 90 minutes after you take your first dose, let's go ahead and redo the test and see if you've improved. So you can actually compare and see. And I've done it so many times myself. I take it for a day, I do the saliva test before and then 90 minutes after, and it's just like night and day. And then I let it go for a while. I do it again just to kind of like compare. It's very fascinating. So I always recommend that. But I'm sure there are other products in the market. You just want to do the saliva testing. And again, our pharmacy, we offer the testing for free. But you could also buy the test strips online and basically do it at home yourself.
So I think we are done with talking about menopause and perimenopause and female sexual dysfunction. And I would like to talk to you about polycystic ovary syndrome. So if you wouldn't mind, can we have another episode where we talk about menstrual disorders and polycystic ovaries and PMS?
Of course.
But for folks who aren't going to continue with the next episode, tell my listeners how they can get in touch with you if they want to get a consultation.
You can always text me. That's probably the easiest way at 602-345-1473.
Great. So is there anything else that you wanted to talk about menopause? We haven't even gotten into the fact that menopause happens to different patients at different ages. Some people have premature menopause. It can happen as early as 38, the average age being 52, and so on and so forth. But that would be another episode. And I'm going to see you on the next episode where we're going to talk about the menstrual dysfunctions.
Sounds good.
Thank you for joining us.
Thank you for having me.
Thanks for listening to Wellness and Wisdom with me, Dr. Nadu Tuakli. If you want to find out more information, head over to drtuakli.com or subscribe to my blog. And if you enjoyed this podcast, please click the follow button on your favorite podcast platform and share this episode with a friend. Wishing you the best of health and happiness. We're in this together. Until next time, stay well.